Good afternoon, and thank you for joining us for today's webinar, sponsored by Curation Health, the new house call, tech-enabled home care for vulnerable populations. Our presenters today are Dr. Brian Davis, SVP Clinical Operations, Concerto Care, and Dr. Matt Lambert, Chief Medical Officer, Curation Health. Welcome, Dr. Davis.
Thank you so much. Happy to be here with you all. And thank you for the warm intro and warm welcome here. So as noted, my name is Brian Davis. I'm the SVP of the Clinical Operations and the Care Partners Program at Concerto Care. I'm a physician by background, but I've spent the majority of my career as a management consultant, and then more recently focused on clinical operations within next generation care delivery models. I've been with Concerto Care for more than 5 years now. Been involved in multiple aspects of the organization, but have really been part of the team that's helped to develop and then also implement our intensive in-home care model, which we affectionately call the Care Partners Program, which I now have the opportunity to lead. At this time, I'd like to turn it over to Dr. Matt Lambert from the Curation team.
Thanks, Brian. Hello, everyone. My name is Matt Lambert. I'm the Chief Medical Officer for Curation Health. I'm based here in DC. Long career in emergency medicine. Matter of fact, I actually did a few house calls back in my training, and I'm so excited to see it come back around to where it really makes sense to deliver care in the home again. But in between that time, aside from a clinical career, a long time with Clinivations with the advisory board and now with Curation Health, and helping health systems select and implement and get value out of technology. So that was multiple chief medical information officer roles around the country, most notably New York City Health and Hospitals. And then when we started Curation Health, it was really built off of a lot of the experience that we got with the Clinivations tool. That is now the offering that is used by Optum to help capture HCCs, to really help capture the complexity of care that we are delivering in home. And as we all know, it's the currency of value-based care is capturing these clinical conditions around that. So happy to be here today. I think we'll go to the next slide as well and talk about our agenda. First thing, Brian's going to talk a lot about a lot of the methods that they're using at Concerto Care around identifying and caring for patients where they are. And again, there are a lot of reasons why we're coming back around to this. And I think we're going to talk about that on some ways to help our provider partners move to value-based care in the home. And to be clear, at Curation Health, our quickest growth area, or our largest growth area, is in-home primary care. And so I think it's really an exciting shift in that direction. And then we'll also talk about ways to use technology and use processes, again, to capture those HCCs, to make sure you're getting the credit for the complexity that you're managing at home. Kim, now, I'm sorry if we can move on to the next one. So, sorry for the back. We're a few, probably preaching to the choir here, but we're getting older as a country. 40 million seniors. Fastest segment of that is the octogenarians. And COVID-19, it exposed so many things and accelerated so many things, but it really made a lot of sense to keep these folks at home. And then how do we do that and still effectively manage their care? And so we made a really big pivot last year here in DC and around the country around risk adjustment via telehealth. There's even a bill in the House for risk adjustment over a phone call. I have to check and see where that's moving now. But also, it just made so much more sense to provide care in a way that best fits the needs of the patient. If that means home medication delivery, if that means home food delivery, if that means telehealth. And once you are in a value-based care structure and on the subscription model, it really frees up different ways to engage patients. And Brian's going to go really, really deep on that as well. And it also creates some, I think has exposed some gaps in between the care segments. The hospitalist model and the ED model I know very well from my clinical career, and it's very efficient at managing that inpatient, but it's left a lot of gaps, especially when in the transition of care visits and a lot of follow-ups around that. So we'll talk about this shifting landscape, ways to best manage it, and ways to best really take advantage of a lot of the lessons we learned, things to do, and quite frankly, not to do, right, Brian, that we learned from COVID-19. Next slide, please. Brian, it's all yours.
Thank you. So a quick intro on who we are at Concerto Care and what we do. So we have a multidisciplinary wraparound services and support, very comprehensive clinical care model that we deliver one of two ways. So at the core of our model is a comprehensive multidisciplinary care team, includes pharmacists, social workers, community health workers, complex care physicians, RNs, nurse practitioners. Basically, the entire set of a team that you would think of that would be needed to manage the complexity of the patient population that requires in-home intensive care services. We use applied geriatric clinical reasoning in all that we do. Dr. Alan Abrams is a team member. He is what many would consider one of the founding fathers of geriatric medicine and also a home care specialist. He helps to infuse all we do in the training, all we do in how we approach our care of these patients with a geriatric understanding to the unique needs of that population. We include social determinants of health, big focus on housing security, food security, transportation support, you name it. We recognize that it's not always just health needs that are impacting a patient's overall viability, that it's impacting their quality of life and therefore their health outcomes. So we take a comprehensive approach to understand and support social determinants as well. Obviously, with this crew here, talking about intensive in-home care for all patients, but it's not always just all in-home. We also ensure that we are using appropriate technology where needed for remote patient monitoring, the ability to do telehealth support as well. But then we also have proprietary technology that we call our Patient 3D platform. And that's where we'll get into some of the additional nuance of what helps us to be successful in terms of delivering in-home care, but also in a value-based arrangement. So our two models are complementary. One we call the Care Partner Program. This is a program that I lead, where we are an in-home provider that provides wraparound support around an existing network of providers. So we are the extender of what a current network looks like. We don't look to separate a patient from their primary care provider. We wrap around that provider and ensure the patient is receiving the needed services in their home. We make sure balls are not dropped, and we actually do our best to keep driving the patient back to their attributed PCP where they have that relationship, and we'll actually work to make sure that that happens. We typically do this for MA plans, but then also we move into risk sharing and full risk, as well as PMPM fee structure for the Care Partners program. In the geriatric primary care program, again, leverages the same care model, but in this model, we are the in-home primary care provider of record. So we continue to provide the PCP, the wraparound services and supports, but we are the PCP of record here. We are that patient's longitudinal care provider. So again, similar level, similar models around these two, where one in the Care Partner Program, we're more of wraparound support around an existing network, and then the other being where we are that PCP of record. Next slide, please. So thought it would be helpful here to actually put color to what that means in the field. So talking through a patient flow journey. This may be typical for what we would see in terms of a highly complex patient, but then also wanted to use this as a little bit of a framework to double tap into a few interesting topics that we can discuss here. Talk about virtual care, talk about preventive care, leveraging technology, et cetera. So going through, we think about a 70-year-old patient, probably not unlike a lot of the patients that you all manage, COPD, diabetes, depression, admitted to the hospital for shortness of breath, COPD exacerbation. So while in the hospital, we actually engage that patient with a transition to care nurse. We help intervene with this patient at this time, help to enroll her in the intensive in-home care program, make sure that she has all of her needs set up for post-discharge. We have found that these transition to care support not only helps to obviously prevent readmissions, ensure all needs are addressed, but for many patients that are maybe not as ready to be accepting of a different care model, accepting of in-home care, we found that in the patient's vulnerable state, they're actually looking for help. They're looking for somebody to come in, and even if it's just 1 or 2 visits, they're much more willing to take that step, to take that partnership. And so we find it to be very valuable to engage patients in the hospital in that immediate post-discharge period as well. Moving into the morning following discharge, same slide, thank you. That's important for our complex care nurse, and then also multidisciplinary team. So you can see here a pharmacist getting to that patient's home and completing a detailed clinical risk assessment. That includes multiple different clinical assessments rolled into one. It then feeds our understanding of patient needs and then later work streams. We also take a very proactive approach to better understand depression, social isolation. Very important to understand here what all is going on with that patient, and being able to provide eyes on patient, eyes on their situation, actually being able to put hands on her pill bottles that were a mess, that she probably was not able to adequately manage, help to clean that up. Looking into the refrigerator, talking about food insecurity, and tailoring that into an updated care plan as well as we think about supporting the whole person. A few days later, the next team member arrives. Nurse practitioner makes a home visit and conducts a comprehensive examination. Physical exam, reviews in detail the previous team findings, and initiates a more in-depth view with Mrs. Jones about depression history and then also her goals of care. Important note here that in this one, this is where we actually have a billing provider that would be able to complete risk adjustment, documentation, and capture for the appropriate level of complexity for that patient. So more on that later. Next slide, please.
Brian, before, I'm sorry, just to add a little bit of color to that, you know, that
Please.
While the patient's in the hospital, there's so much falls on that discharge nurse. A lot of times there's a lot of regulatory requirements there and a lot of just really patient care that has to go in there. So I think to support that makes a lot of sense. Also, when you're starting to think about RPM provisioning, that's a really good time to do it because there's usually some logistics that need to be done to help set that up. Really managing effectively the social determinants of health with that first visit, just checking on the patient's well-being in general and risk assessment. And then, as you mentioned, an opportunity to capture the complexity on that day 3 visit. So, I mean, just a really impressive model. Yep. And really well thought out.
Thank you, Matt. And I think that all kind of feeds in. So there's that heavy initial upfront touch that's the inpatient assessments. It's the immediate post-discharge. It's the then almost immediate follow-up of the advanced practitioner. Then the team huddles, multidisciplinary care team. That includes social workers, includes operations team members. It includes community health workers, pharmacists. They develop the comprehensive care plan. That again takes the whole person into account. It's not just a patient with COPD exacerbation. It's a patient with COPD exacerbation that has food insecurity, that has underlying untreated depression. So thinking about who are all the team members that we can bring to bear to help support this patient. They develop a health coaching plan focused on food security, social work to support for bridge counseling, and mental health support and referrals. Then we start to tie into our predictive analytics. So Patient 3D is our platform. We use a predictive score, apply that to the patient based on a composite of their assessments. And then from that, we determine the proactive need for reach outs and visits. How's the team assigned? What's the frequency of touches? Should they be more in-person leaning? Should we use more telehealth where appropriate? So we build that in and then recalculate that on an ongoing basis to determine what is the level of need and how do we support that patient in a proactive manner. We continue to support weekly check-ins, heavily leveraging social work and community health workers with that patient. Virtual visits are heavily leveraged here. Again, that helps to extend the team, increase the frequency of touches for that patient. The team helps connect her with Meals on Wheels and sets up a permanent counselor for the behavioral health. 2 months later now, let's fast forward. Per Matt's point, we use that post-discharge period to set up remote patient monitoring and put in a specific type of telehealth engagement support in place. So the patient has a COPD exacerbation. Symptoms are detected through self-reporting and then also through the remote patient monitoring through the pulse ox. We activate her COPD rescue plan, which we have developed with the patient. And then we have a same-day visit applied where a nurse practitioner actually comes to her home, administers treatment with antibiotics, steroids, nebulizer for a short run with some home oxygen as well. We provide her then with daily check-ins and is back at baseline 7 days later without having been to the hospital for a readmission. So you can see how all the different pieces start to come together here. And now in the next couple of slides, we'll talk about where we've highlighted some of the little nodes here for the frameworks. Next slide, please. So again, highlighting here, the first one that Matt called out, transition of support, as we start to think about, and again, we could probably draw up 50 or 60 of these things out of this, right? But recognizing the times constraints and what we're focused in on here, making it, narrowing down a little bit, transition of support. Engaging those patients immediately in the acute setting not only helps relieve the burden, as we noted, hospital administration, community providers, but it really helps to take the burden off the patients and their caregivers as well. Help to ensure an easy transition. And in order to be able to support this, something to keep in mind is how do you get the timely notifications of admissions and discharges? We have found the best way to do that, and what we utilize is health information exchange integration, and then also in some cases, hospital integration. It's really key to have that timely data in order to kick off the TOC workflows, align resources to support the patient, because relying on the patient to let us know that they've had an acute event, usually we won't find out until either they've been readmitted or a couple of weeks after the fact. Relying on community providers just isn't, their folks are so overwhelmed with what they need to do. So thinking about, there are ways, how do you tie into the automation? How do you tie into that workflow for the automated notifications? And that continues to improve. And the health information exchanges are getting better, but then also direct hospital integration as a backup for that is also very important to consider. In-home assessments. So obviously speaking to the right team here, but in-home assessments, whether post-discharge or ongoing evaluation, are critical to get the whole picture of patients that you may not always be able to have by telehealth. So the risk assessments help to inform the protocols and reduce the risk of decompensation and readmission. But it's all about being able to get more of these experts' eyes on the patient in a logical manner. Shared expertise among our clinical teams helps to ensure all facets of clinical care are appropriately managed. And then the whole person care, it's making sure that we really do take that social determinants of health into account, thinking about how that is different, how that is nuanced for the complex and frail patient populations. We think over and over again, the times that we've been on the phone with the patient, the times that we've been forced to do a virtual care visit during COVID, and the patient says everything's fine, home's okay, I'm doing okay. And then you get into the patient's home and you see a bunched up rugs where there's just fall risks all around. You see that there's clutter stacked around, and there's basically an untenable or unsafe living situation. You have the opportunity to work with them and look in the refrigerator and actually understand if they are having a diabetes exacerbation because they don't have access to fresh food or have a good, adequate food supply. So it's not to minimize, I don't think the need and the importance and the value of in-home assessments can be minimized here, given the complexity of what the patients that we see, and then what has become a very heavy reliance on telehealth in the last year here. Following that, it's not just the in-home assessments, but then it's the comprehensive examinations. So clinicians, the billing providers, the advanced practitioners, MDs, DOs, those visits are going to be optimized when they can take part in a comprehensive but targeted pre-visit preparation. So we don't want to take clinicians and send them into the home blind. And we think about the clinic starts to become a more familiar setting for folks. You have access to more tools, you have access to more resources. You can holler out the door and ask your MA for additional support or a gap list or a chase list or what else was going on. You're a little bit more on an island if you're doing the in-home comprehensive examination. And so that's where the pre-visit preparation that becomes very targeted, that helps to include, and again, this will be discussed in much more detail with Dr. Lambert's section, but identification of the chronic conditions and preventive care management opportunities. How are the providers seeing that before they go into the home so that they're prepared? They have their checklist that, again, is probably going to be superseded by the patient's immediate clinical needs, but how do they always have that top of mind, back of the envelope, ready to go, so that they know when they have the appropriate time and ability to do that, they can take care of those open gaps. So we think about point of care solutions, EMR integration, those types of things where you take the burden off of the provider. That's where you're going to start to see the highest levels of compliance and accuracy. And one of the other pieces too is we don't want to have our most expensive resources spending a ton of time in the car. So windshield time, the goal is to always minimize that. Have to always be thinking about optimization of patient scheduling, route optimization, et cetera. We use route optimization through a Salesforce tool that we have built, and we're continuing to leverage and work with. And I think, there is no perfect answer, because these patients it's not like we're a cable company adding somebody or fixing somebody's internet. This is patient care. This is about patient-centered treatment. So, there's no perfect solution for it, but I think it's something that we're all focused on and making sure we do the best possible by the patient, and then also for the clinicians that we're dispatching into the patient's homes. Next slide. And then how do we think about this too? I mean, because we don't just want to be setting a protocol of every 3 weeks, patient gets called by this provider. Every 2 weeks, this provider goes to the patient home. We have to be more intelligent than that. So it becomes a key about predictive analytics. You want to make sure that we are using the right care delivered at the right time by the right team member in the right location. So a lot of the in-home care preventive medicine is really a race against logistics and prediction, because the entire goal is to ensure that the patient isn't going to decompensate, that they're getting the care, the stability that they need in their home, so that they don't have to seek care in a more acute setting. So the back-end analytics engines help take this guesswork out of the provider-facing platforms as they interface, and so that we can be assured that we are being as intelligent as we possibly can about making sure that we are being proactive in our touch points, that we're being proactive in who we send to the patient home. Because I'll be honest with you, I would much rather be able to send a community health worker out to a patient home to prevent an admission if possible, than having to send a regional medical director out. There's just value in being able to leverage the appropriate team members at the right time. And then there's the virtual visits. It's a critical, I know I said that there's only so much you can learn from them, but it is absolutely a critical component. It helps to extend the reach of the teams. Face-to-face is critical, but those really can help, the telehealth can help bookend those visits. Always important to have somebody in the home, but it's a better way to increase the frequency of engagement, leveraging the virtual visits. We have also found for us that it's easier said than done to do a telehealth visit. It can pose a challenge for many patients. There's technology access, there's the complexity, there's the applications, there's the I don't have Wi-Fi, it's unbelievably complex for a series of patients, especially those that typically haven't been well served or have fallen through the cracks of the healthcare system. So I think it's important to have planning and think through alternatives to traditional telehealth. One of the things that we do and have found value in or consider expanding further is what we call assisted telehealth. So maybe we want the patient to have a provider-facing visit, but they haven't been able to access telehealth previously. It can make a lot of sense to send an LPN out to that patient home. They could do a basic physical assessment, take vitals, et cetera, and then actually hold an iPad in front of that patient and ensure 100% compliance rate with telehealth. There's an interesting study that Gary and Marianne, the West Health PACE centers did, where they were looking into telehealth for their patient population. They enrolled about 100 patients. I may be a little high on that number, but about 100 patients into a telehealth program. That was a pilot. And they essentially sent a geek squad out to that patient's home with Wi-Fi routers, with the technology, with an entire training team, train the patient, train the caregiver, train them on everything needed to do a telehealth visit, and actually did a dry run practice on telehealth visits. At the end of the experiment, they were only able to complete 50% of the telehealth visits as scheduled within that pilot program. So it just shows that there are so many things that can go wrong for this patient base. It's really thinking about how do you mitigate that and what is the alternative? And that's where some of that thinking about that assisted telehealth starts to come into play. And then the last piece here is the remote patient monitoring. And I'm sorry, on the virtual visits, as Matt mentioned, when documented and billed appropriately, telehealth is going to impact risk adjustment for the foreseeable future. Now, there's a lot to take in as it relates to this, because I think all folks, we need to be very well aware of the compliance requirements tied to that. There's going to be increased scrutiny in terms of modifiers and that were used. And I'm sure there's going to be a lot of compliance retrospective reviews about appropriate billing and management of telehealth visits. So I think ensuring an airtight process in terms of how telehealth is managed and billed is absolutely critical, not just for now, but then also for going forward and for compliance protection as well. Last piece here, and then I'll turn it over to Dr. Lambert, is remote patient monitoring. Ongoing patient monitoring, again, it's all about further extending and increasing the efficiency of the clinical teams when they're delivering in-home care. Helps provide continuous eyes on patient. Now, what's interesting though is in a risk-based environment, the consideration to patient selection starts to become very different. In the fee-for-service world, we were all guaranteed an adequate rate to pay for the investments in remote patient monitoring. When that goes away, obviously the scrutiny in terms of patient selection, patient benefit for remote patient monitoring starts to take a different turn. So I think there's a lot of thought that has to go into patient selection here. And it's not just about what patients would benefit, but it's about ability to comply, caregiver support, et cetera. And I wish I had the answer to all of you and say, hey, for diabetic patients that meet these criteria, these are perfect, set it and forget it, and you're going to get an ROI on that. But I don't think we've discovered that yet. And again, there's nuance to it, there's patient experience, there's market difference. But it's something that we are heavily focused on and is a core part of the model that we deliver and will continue to deliver.
Ryan, great stuff. Just a few high-level comments, I think, on that. I agree. We're in for a correction, I'll call it, with telehealth regulation, and that might come at this point. I don't know. That might be 2022 before we see that. But really, what we're doing here is you're taking care of folks at home where they do better, right? I mean, when it comes to fall risk, it doesn't exacerbate dementia as much. You get hospital-acquired infections. You take that off the plate. You're managing them in a way that makes the best sense for them. And you just really described that really well, the nuances of what you've learned and what you're continuing to learn around that. But the reason you're able to do that, and again, really big high level here, is because the reimbursement model is different and allows you to get really creative in how you do this. And the technology has gotten better and is continuing to get better, really accelerate, quite frankly, in a way that a lot of this makes sense. So there are a lot of things that have changed recently, even pre-COVID too. But that really make this model very exciting. So great stuff.
Great. Thank you.
Thank you. All right, we're going to go to talk a little bit more about some of the chronic condition capture. But first for that, we have a poll. And it's we'll have one here and one in a little bit. And so, would you find value in putting more tools in the hands of the providers for managing total cost? So this can be, and again, where Brian was talking about that comprehensive visit where the provider is working at the top of their license and in the home doing a comprehensive visit. What kind of tools would be best, or would you find value in submitting some of that? And while we wait for the answers, I'm going to go ahead and talk about the shift. Everything is shifting, right? And we're talking about retrospective capture versus prospective capture. So the doing this after the visit or searching for this data post-visit is becoming less and less attractive. And whether that be from, we see a lot of our DCE, direct contracting entities, there's a lot of urgency associated with that, of getting it right. And also the shift to encounter data only from RAPs is really moving this in a prospective way. And done a lot of this all over the country and with Curation Health and also with with the advisory board around provider education for this and for HCC recapture. But the next step to that we found at Curation Health is really providing a different level of clinical decision support. And this means we can do hardcore clinical decision support, i.e. this antibiotic might work best for this condition. We're currently not doing that now, but it's care gaps for sure. So we can certainly pull care gaps forward that have been prioritized for that patient and for that plan, and can differ from plan to plan. And then also a subdivision of that, which I've started to call clinical documentation support. Most of us were trained in an E&M world. Most electronic health records were configured for an E&M output. So to really help our providers make this transition, they need some clinical decision support, and done so in a prospective way. Next slide, please. All right, let's check in the time. So with this perspective approach comes that it's got to be more than recapture. It has to, it's got to be, we have to minimize the false positives associated with this. We've got to integrate it as much as we can in the provider's workflow so that they're going to work on it in an actionable way. And a lot of this is pulling in different data sets or different things that we historically haven't seen at the point of care. And so that's payer insights, pulling those forward can be very valuable, especially in these shared risk arrangements. HCC recapture is certainly a bedrock of what you have to do in value-based care. Pulling quality gaps forward and prioritizing those in a certain way. And then also suspecting, pulling this data together and putting it together in a really a thoughtful way, a way that clinicians are used to seeing it and things that make clinical sense. My team would be very upset on this webinar if I didn't say common things are common, and really focusing on making sure that you're capturing a lot of those really common conditions that are driving a lot of outcomes, a lot of utilization, a lot of cost. And of course, doing so in a team-based approach. We have a separate slide on that here in a little bit. But doing it in this way also allows for good audit support too for a Red B audit. Next slide, please. All right, when organizations who do this well, how do they do it? And we broke this down into three buckets here. We have the curate, or the pre-visit step, capture again at the point of care, and confirm is that post-visit pre-claim step, just to make sure all that work that we did before that has gone for naught. And so when you think of that pre-visit review, this is a really good way to use AI and technology. It's still got a ways to go, especially if you're going to put it directly in front of the provider, but keeping your platform up to date with the latest regulations or shifting regulations that come out every October from just down the street here in DC. That's a really good use of AI, right? That is a really good use of technology to keep up with that. And then also to have that to drive some efficiency in that pre-visit review. We're just always more confident when we can have a human with some clinical training, usually maybe an RN, validate the output of any sort of NLP or assistive technologies. Capture, got to get this at the point of care in a way that providers are used to seeing it. If you want to keep them engaged with the tool, we have to make sure that we're minimizing false positives with that. And we have to make sure that we're as integrated as we can with the electronic health record. That's really too, when you start making some tough decisions about your technology. Is your EMR going to be able to support APIs? Is your electronic health record supporting enough customer service for you where they're going to be able to willing to work some things with you that will really push things forward? And then confirm, again, a post-visit pre-claim step to make sure that we've captured that new diagnosis or captured the correct diagnosis, and it's going to be supported with technology just to make, or excuse me, supported with the documentation, just to make sure that all of this work does not go for naught. Next slide, please. Busy slide, and really, again, the purpose of this is to say that you probably need to think about this from a team-based approach. Clinicians, we're getting more and more used to working as a team, and the model that Brian just described earlier, it's key, right? That your physicians are the leaders of that team. And so if you notice on the capture, the physician column here is one column. And before that, we have 4 columns that talk about we're trying to do this with technology, and with a human validation to make sure that we're presenting the best information we can at the point of care and really putting a team around providers as they're trying to make this transition. So pre-visit, at the point of care, post-visit, putting a team with services and technology to really make it work. Next slide, please. All right, it's been very it's been fascinating to combine different data sets and get value out of it, right? Half of all healthcare data are time date stamps. That's not very useful data. Of the 65,000 ICD-10 codes, only about 10,000 of them map to something that has that equates to value in a value-based care world. So when you start looking at other data sets and combining them in a certain way, you've got to be really mindful on how you do that. And again, it's always a lot of the recapture has been built off the problem list. In our previous lives, we had solutions that were driven solely off the problem list. But using problem list and claims as the bedrock for that, and then combining that with a new lab value, a new medication, device or procedure to make sure that you're capturing the specificity that you need as the patient's going down their disease state journey. And then also like provider notes, maybe things that providers, giving them some assistance around something that they don't have time to look for or weren't necessarily trained to document on. So here we think of wound care, we think of physical therapy, we think of occupational therapy, pulling those things forward to have the providers address them in a way that, again, gets you credit for managing the complexity that you are. And then we also think about just the alphabet soup of ways to do that, right? A provider, anyone on the care team shouldn't have to be thinking about this patient is in this plan, so these codes apply, and these quality measures apply. So again, it's a good use of technology in a pre-visit space to parse all that out. So whether it be the CMS model, whether it be the HHS model for the exchanges, whether it be Medicaid on a state level, and Brian, I think a lot about Medi-Cal and a lot of the nuances there, whether this be something specific to a particular ACO, or this could be an internal initiative that the organization could say, hey, we're going to make this a priority. Making sure that using technology to make that sticky is something that we're a big believer in that pre-visit step. Next slide, please. And again, we just move through this pretty quickly. This is just focusing on some assistive tools around this. We're looking at the pre-visit review within the Curation Health platform and a way to help any pre-visit reviewer, whether that be a CDI, whether that be an RN, whether that be an MA, isn't looking through the medical record trying to find the needle in the haystack, the things that are important to them, whether it be around quality, whether it be chronic recapture, or whether it be maybe a new diagnosis that the providers are probably already managing anyway, but they haven't presented it in a way that they're going to get credit from it. Again, just trying to be as simple as we can in that pre-visit review using technology and services. Next slide, please. Point of care, pre-COVID, we and at Curation Health and some other previous initiatives, we supported this in person at the elbow with providers. And if you want to get a lot of real-time feedback about the workflow and the content that you're presenting, just stand next to a provider as they're trying to go through a lot of this stuff. So we are hyper-focused on minimizing false positives and hyper-focused on getting this as integrated as we can with the electronic health record. And again, there's a lot of variance there. It's got to match the workflow that Brian mapped up so well at the beginning, but ideally this would be digital, it would be within the electronic health record or within the browser. So if a provider's in the field with their laptop and they can do their documentation and capture it there, they can have an integration that's pulling forward these prioritized things for them to consider. Next, please. And again, the confirm step helps certainly with any compliance challenges, helps coding and billing accuracy. And quite frankly, in some of our previous ventures, we didn't even do this post-visit step, right? We just assumed that everything was magically going to happen based on some of the pre-work or the work point of care, and we found that not to be true. And ideally, there's not much to do post-visit, right? If we've done the right the work that we've done before, but this is also a key step in making sure that that you're working as prospectively as possible. Moving on, please. Okay. And again, this is just some functionality that you can see for that post-visit pre-claim review around ways to make sure that this is going to be, this diagnosis is valid, make sure it's supported with documentation, and make sure whether it be MEAT or tamper, whatever methodology you might be using. And then also to track where you've reached out to a provider to get maybe a more specific diagnosis or to get some other documentation around. Next slide, please. All right, I think we're going to have a second poll here. And for those attendees, do you currently utilize any HCC capture features or tools at the point of care? And so we'll go ahead and move with that, and then we'll talk about some of our case study slides here, and then we'll go. I think we're good on time, but leave plenty of time for Q&A. Yeah, we're good. So this case study here was over 2.5 months. And this was, unlike Brian and what they're doing in Curation, this was an IDN that has some risk-based contracts mixed in with their fee-for-service business. So not quite as much emphasis on the model and mixed in with it, but the really remarkable results. Again, as a CMIO or the CMO, you hear a lot less if you have a net promoter score at 9 out of 10. And again, that's that focus of minimizing false positives. It's that focus on integration, but it's also on feedback. They're it's very important as providers give you feedback about what they're seeing and what their workflow is like, to respond to that, to hear them and make adjustments in either your process or your technology is a really good way to keep providers engaged. And so when you have engagement, you're usually going to have results. And so we can see here that we can see in a less than 3-month time, we can see a real improvement in chronic condition capture and new condition capture, all the way up to even a $30 PMPM equivalent return. Just really focusing again on those basic conditions, chronic conditions, and focusing on the team and the workflow around this. And then the next one is the next slide, please. Kind of talking about suspecting, and we have some numbers here for the PMPM variance. So we see anywhere from $18 to $30 in a couple of these other case studies where you can see an improvement in your performance, driven off your improved quality scores, driven off your improved HCC capture, but also your improved outcomes. And interestingly enough, in this particular study, we were able to identify 1 in 14 new conditions in a patient population. And we've seen that vary as low as 1 to 8 and as high in this particular case as 1 to 14. And again, a lot of these are conditions that you're managing anyway, but they need to be presented in a certain way so you can get the credit for the complexity that you're managing. And we see our polling slide here. It looks like currently do it within the EMR, a third. We do with an outside vendor, and currently do not, but would be interested, about half of the attendees there. All right, very good. So we'll go ahead and go to the next slide. I think we've got about 15 minutes left. And we've got this some time allotted for Q&A. Before we go too deep into that, here are Brian. They were supposed to put your personal cell phone on this slide, but they didn't do that. But here's,
I pulled that off.
But here are the best ways to contact either Brian or I or our organizations for any further questions or about processes in providing this care or capturing this care. And having said that, I'm going to now move down to and see we've got some, or Kim or Elizabeth, are we going to have some help with the questions, or do you want me to just go at them one by one here in the Q&A?
Yes, sir, Dr. Lambert, I've got it. Our first question is, how do you think technology can be used within the home as to not put more burden on the physician or nurse practitioner?
Yeah, so I have a couple of thoughts on that if you want me to jump in, Matt.
Yeah, and then maybe you focus on the care and I'll focus on the capture. Does that make sense? Or
perfect. Yeah, perfect. Let's do that. So, I think in terms of how we've looked at this is that we can see there's a opportunity for significant burden on the clinical team if this isn't done appropriately. Reams, the problem with continuous data is continuous data. And being able to search through that data and make sense of it. So I think the key piece here is to, first of all, identify what is the problem, what is the need that you're trying to solve. So if we're just looking to manage diabetic patients better, well, what is it? Are we trying to prevent acute admissions? And then if that's the case, then you start to drill deeper and deeper. And it needs to have a very prescriptive reason, a very prescriptive question to be answered by the remote patient monitoring technology. And then beyond that, is thinking about what is the layer of support around the provider that can consume and take and acknowledge the data, and then also look for the alerts or the red flags that need to be acted on and start to distill that. So I think if the question is, if the provider's practice does not have resources with which that can monitor and look at that data and look for the red flags, then it's looking for the vendor that can provide not only the technology, but then also the oversight. And then maybe even the first outreach to the patient to make sure that the continuous glucose meter was working appropriately, and they didn't just get an error that's going to trigger a provider's follow-up because the system just wasn't working. So I think it's being very prescriptive and understanding the question that is being asked, and then being very honest with what are the different levels of support to get down to the point of where the clinician is only being involved when there is a clinical evaluation that needs to occur, or clinical intervention that needs to occur. And so it's peeling back those different layers of support and being very honest about what can be done internally versus where there's additional resources to support, or where a vendor needs to be brought in that can support with all of that, and then starting to answer it that way. So it very much can be done, but I think a very pragmatic approach and understanding of capabilities and resources to align to the answer is absolutely required for that.
Yeah, Brian, good stuff. And ideally, when we partner with someone like Concerto, we would want to, ideally the in-home provider is there with their laptop. They've got reasonable connectivity. They can work directly within the record and get some insight from an outside source of saying, hey, this work's already been done. We need to make sure we're capturing this. This patient is in this plan, so these are the 3 priorities, maybe from a quality standpoint around that. And so we would try to present that quality information as integrated as we can. If we can't do that, then we would look at a patient brief that maybe the provider carries with them, and can look at that and maybe again address it right at the point of care, or maybe immediately after. The alternative to this is maybe getting some a sheet, nothing at all, right? Of having to sort through all this on your own without any prompts or without any filters around this, or perhaps maybe getting a list, a large stack of printouts from the provider, or excuse me, from the payer, in a way that doesn't necessarily prioritize particular things, and it requires the provider look through a lot of information to find what's meaningful. So to again, just those focus on the point of care, focus on the quality of the information, and focus on the integration whenever we can.
Thank you both.
Thank you.
Dr. Lambert, I think this one will go to you. Why is HCC recapture important for home-based care?
Yeah, the risk model of home-based care, full risk, it's on an HCC model or a subscription model for reimbursement, as opposed to paying for the visit here. So if you're in a more conventional world, you're asking your staff and the patients to adopt to a model of, I come into the clinic, we do a standard E&M visit. Maybe we do some of these other social determinant pieces or risk assessment pieces, but it's done in a way that there's a lot left to follow up. So doing this in the home and capture that, those HCCs make sure that you're getting credit for the risk that you've assumed and for the complexity of the care that you're providing. And the other thing too is when we compare risk scores at a population level from some of our other partners around the country to in-home primary care, the in-home primary patients always have a higher risk score, some over 2. So a risk score of 2.1, 2.2, 2.3 at a population level are some sick patients. And so you're going to want to make sure that you're capturing all that complexity, but you're also delivering it in a way that is very easy for the patient to receive the care done in their home.
Thank you, Dr. Lambert.
Okay.
Dr. Davis, I think we'll let you start with this one. How does providing care in the home provide a more holistic picture of the patient?
Yeah, I think what we've experienced is that the patient is more open and they're in a much more vulnerable situation in their home. And so I think we have to be very cognizant of that and very respectful of that. But also in that you see the deeper level, and I think it actually, to be honest with you, I don't know that it's that you're going to see a better clinical picture of a patient in their home, but you see everything else that makes that patient who they are and why they are. And patients, when they come into the clinic, especially in this patient population, that can become a big outing. They may be more dressed up. They may be doing their makeup. They may be pulling it together to present well to the clinician when they're having their appointment. But when they're in their home and when you actually get into their home, you can actually see what their life is and how they are living. And that's where I think it becomes much more about the whole patient care, where the social determinants of health starts to play a much bigger role. It's completely open. The patient is completely vulnerable. But that's where you actually can really lean in and start to provide the heaviest dose of empathy and support. And we actually can understand what some of the root causes are behind some of the medical problems. Well, why was the patient in my example, why was she having a CHF exacerbation or COPD exacerbation? Maybe it wasn't because she wasn't trying to be compliant with her medications. It was because she had 15 pill bottles and 12 of them were expired, but everything was just prescription on top of prescription, and she didn't know how to manage it. But she wouldn't necessarily admit that coming into the clinician's office. She wouldn't necessarily admit that she was having food insecurity, or that she was uncomfortable getting to the grocery store, or that she didn't have a ride to the grocery store to take care of those needs. So I think within that, that's where you start to really see who the patient is. And that's where you can also start to see what matters to them as well. We see times where you see the picture of them with their grandchildren, and it helps you to understand the importance of value and family within that for that patient. Start to discuss how that may have an impact on their goals of care as you're developing the patient-centric care plan. It becomes less about let's manage your diabetes and let's manage to what will make you happy and healthy and be able to live your longest, most joyful life.
Yeah, Brian, well said. Well said. You can identify immediately, food challenges, right? Identify mobility challenges, right? Maybe that COPD patient is having exacerbations because of all the dander in that rug in the living room, right? I mean, and if pulling a rug out of the living room saves you an admission, that's money and effort and time really well spent. So well said.
Thank you both. It gets me a little choked up listening to all of that. Sorry. I was reading the message that came through from a nurse that was sent a message into Dr. Davis while you were talking.
Yeah.
Dr. Lambert, I think I will let you close it out. You have any last words for our attendees?
Well, first of all, thank you for having us, and thank you for everyone for attending. Thank you for the questions and again the great part of the chat. We've come back around to home care, right? Partially because of necessity, partially because of a different revenue model, and partially because of evolving technology. And this is an area that is growing very fast in the market and with our provider partners. And no one does it better than Brian and Concerto Care. So any questions about best practices, things we've learned, things that we've learned not, or any other questions about the model, again, whether of providing care or capture care provided, you see several ways to get a hold of us here, and we certainly welcome any ongoing discussions around that. So thank you so much.
Thank you, Dr. Lambert, and thank you, Dr. Davis. A wonderful presentation. And thank you, attendees, for joining us today. And remember to please take 60 seconds at the end and complete the survey. We would love your feedback. Thank you all and have a great evening.
Thank you.
Thank you.